You're part of a unique organisation, really, and I don't know if you appreciate that. You're one of the few organisations that wants to get smaller with time. Just think about that. It's an extraordinary thing. And we are getting smaller as a group. People are dying off at the top end, I'm sorry to say, and not being replenished from the bottom. The consequence of that is several-fold. First of all, the awareness in the general community about polio gets less and less. The motivation for vaccination starts to drop away because people forget. And I'm not sure if you've seen those famous slides of hundreds of iron lungs in school halls. And we have a lot of problems still persuading people that vaccination is good because it's not natural. Well, the natural way of vaccination for polio, of course, is to get polio. And although you may recover, you're left with a disability. So my brief today was to talk a bit about sleep. And I thought that the best way to do that is to just get questions from the floor. We'll cluster those into groups, and then I'll just talk to those to hopefully make sure that we've covered the questions that you'd like to ask. So, who wants to start off?
Cramp and leg pains wake me up.
Yep.
And I have to jump out of bed and, you know, let the cramp go. But sometimes it's not only cramp, it's just leg pain, and it doesn't matter how much walking you do, it doesn't seem to disappear for a few minutes. Well, when I say a few minutes, 5 or 6 minutes. Cramp, you can usually push on it and get it to go away. But that's what wakes me up.
Okay. So that's clustered under the bumps in the night section.
Sometimes you just wake up for no apparent reason.
Right.
Don't go back to sleep. Mm-hmm.
Right. That's under the DIMS section. Any other specific questions about sleep, or I'll just run through a reasonably logical talk?
Restless legs I suffer from. Not a lot, but, well, like not once a week, but at least twice a month.
Okay, restless legs, part of the bumps in the night section. It's a common disorder. There's even a society for you.
And what about when your mind goes silly all night? You wake up in the middle of the night and then mind you don't like having
Might be just stupidity, confusion, alcohol withdrawal, racing mind. Any other particular issues?
No, you mentioned one on alcohol.
Okay. We'll mention alcohol as well.
Yeah.
Let me ask you some questions then. Why do you sleep? Tired. What's tired? Physical tiredness is different from sleepiness. So why do we sleep?
To replenish the body.
Replenish the body with what?
More energy.
Energy comes from food. Unless you eat in the night, you're not doing that. An interesting question, isn't it? It's to replenish the brain, refresh the brain. It allows the brain to do stuff without being distracted by doing other stuff. If you haven't already gathered, I'm a very simple person. There are two parts to memory. Not sure if you realise that. There is incident memory. So you see somebody attacking somebody else with an axe in a supermarket, and you remember the incident. there are certain parts of the sleep rhythm that help remember incident information. There's another part of the brain and another part of sleep that helps you with the situational memory, which is being in the supermarket. And they're stored in different bits of the brain. And as time goes on, you can mismatch. You can remember the incident clearly, but you place it in the wrong scene. The best thing you can do if you're a student is to study at night. Go to sleep without alcohol and get slow wave sleep, because that allows you to process and remember what you've taken in that day. That's a technique which I used very effectively, except for the alcohol bit, and I managed reasonably well, mainly because people thought that I had a doctor father, which I didn't, but it helped me get through medical school. So I'm going to talk a little bit about normal sleep. The reason that we know sleep is important is that every single organism sleeps. Flatworms have quiet time and active time. Mice have active time and sleep time. Birds sleep. Birds can sleep while they're flying. Dolphins sleep. How does a dolphin sleep?
I know fish sort of,
Yeah, fish are okay because they don't drown. But if a dolphin has to keep swimming. That's right. So they have hemispheric sleep. One half of the brain sleeps and the other one's awake. What about the Indus dolphin? Freshwater dolphin, swimming in a river, has to keep facing upstream. How does it sleep? Well, it has micro sleeps. So it's half asleep all of the time, or half awake all of the time. The other reason that we know that sleep's important is to do with immunity. How many of you here have farmed or been on farms? Excellent. So how do you set the stocking rate in a paddock on a farm?
Well, you just, you know, 6 sheep to the acre, or if the property's not quite good enough, you might only set 4. But
Right. So you're basing it on food supply.
yes,
Yep, that's what most farmers do. That's why they weren't doctors. What governs stocking rate is to do with sleep. Why can you only stock a paddock with 1/10 of the number of deer that you can with the number of cows? They don't eat 10 times as much.
you're pretty mad, aren't
They are mad. The reason is that deer have alarm signals. The wilder they are, the lower stocking density they have to be. Because otherwise, the deer are too close to each other, and this one wakes that one up with a whistle or an alarm signal. And if they don't get any sleep, their thymus gland gets smaller and smaller and smaller. Their T lymphocytes get lower and lower. They get infection in the herd, and the herd's killed. So you might think it's food, and of course in farm animals it is, which is why the stocking density of sheep is higher than that for cows, but deer and cows are different. So how long should we sleep? 8 hours?
4 to 5 is normal for me.
4 to 5?
11's normal for me.
11's normal?
2 or 3.
Well, those are all wrong. The answer is enough. How do you know you've had enough sleep? You wake up and you can't get back to sleep again. If you wake up, kill the clock, snuggle down, and you're off to sleep again, you had inadequate quantity or inadequate quality of sleep. If you sleep longer in the weekend than you do in the weeknights, then you've had inadequate quantity or quality of sleep in the week. It is not normal to nod off in front of the television set. It's not normal to nod off in a meeting, and you damn well better not do it here. Common doesn't mean normal. It means that you have an abnormal sleep pressure. So the normal sleep duration is a bell-shaped distribution around about 7.5 to 8 hours. But there are some normal people who are 4 to 5 hour sleepers, and there are some normal people who need 14 hours. It's like any population variable. As you get older, the quality of your sleep changes. You've probably forgotten that your teenage children used to sleep for yonks. But they wouldn't go to bed till 1 in the morning, the little buggers. And in the morning, when you got them out of bed, you needed a crowbar or 3 alarms set 15 minutes apart, or a dog. So a teenager has a lot of slow wave sleep. When you're in slow wave sleep, a bomb could go off in the room and you wouldn't wake. As you get older, to about 70, 75, the amount of slow wave sleep gets less, and you have stage 1 and stage 2 sleep, which are lighter forms of sleep. And that's one of the reasons that your perceived sleep quality gets worse as you age, because now environmental stimuli can wake you. And environmental stimuli, which is the one that's the worst possible thing, except for 2 respects. No.
The grandchildren.
No. It's the bed partner. If you sleep with a bed partner, it's terrible, because they turn over and they fart and they belch and they jerk their bloody leg, you know? If you had slow wave sleep, you wouldn't mind. But as you get older, it will wake you. And then if you've got an active brain, you can't get back to sleep. So that's one of the reasons that older folks don't get such perceived good quality of sleep. And for those of you who've chosen to sleep apart, you'll realise that it's very difficult to get back to sleep together again, because once you've slept apart, you realise how much it was disturbing you before, putting aside the snoring. Now, normally we go to bed when it's dark, and we would wake up with the dawn light, and we'd go out and kill an antelope. Modern society has changed that. So now we have evening light. Worse than that, we watch television, or we're on Facebook, or you guys might be on Facebook. I refuse. Television and computers generate blue light. Blue light suppresses melatonin. And melatonin is the body's natural sleeping hormone. When we wake up in the morning, we're meant to be exposed to bright light, which suppresses the body's melatonin to allow us to wake up. What do we do now? Well, we stay in bed till the last possible minute. We don't eat breakfast the way we used to as a family. These are social changes. We get into a car. We drive to work at 7 in the morning because I don't want to be caught on the Green Lane roundabout at 8 o'clock. And I'm never exposed to more than 500 lux of light. Whereas I need 10,000 lux for about 30 minutes to suppress my melatonin and to start my body clock again. That's what the problem with the teenager is. They're late to bed, late to rise. And if they were allowed to do that, they would be fine. The trouble is their parents try and get them up out of bed to go to school or go to work. And that would be the equivalent of making you guys get up at 3 in the morning and go to work. You're chopping off the last third of their natural sleep time. Making them go to bed earlier doesn't help because they're not ready for sleep yet. So what are they going to do when you send them to bed early? They're going to be on their bloody iPhone or on their iPad or both, or in my daughter's case, laptop as well, under the bed covers, being exposed to blue light, which is delaying sleep onset even further. What they need to be doing is bringing their body clock back by avoiding bright blue light at night and being exposed to blue light in the morning. And we get enough blue light in daylight. So in Auckland in the summer, we don't use light treatments that are green or blue, but in some countries we do. If you don't get enough light, you can get seasonal affective disorder or depression, which is a particular problem in the Northern Hemisphere.
What about daylight saving?
Daylight saving is fine, so long as you get out in the daylight. But the trouble is, we're not very good at getting out. We should be eating breakfast al fresco, outside, but we don't. So that's a bit on normal sleep and its importance. And then the things that go wrong with sleep. What's the most common sleep disorder?
Waking to go to the toilet.
Right, you can have a bladder problem.
Dreams.
Dreaming, we all dream. Every one of us dreams about 5 times every night, even as we age. Dreaming sleep is an important component of memory and concentration and incorporating new data. It's the brain's reboot, if you like. Whether we recall a dream or not depends on whether we've woken in rapid eye movement sleep. If I've got brainwave monitors on and I wake somebody in REM sleep, 90% will recall dream content. If I wait 5 minutes after the end of the REM period, only 60% will recall dream content. If I wait 10 minutes, it's down to 20%. And then it drops to around 15%, which is the usual dream recall rate. How many of you very occasionally catch a very early flight? So a few. Barry, you'll remember on some of those occasions you would wake up and you would remember your dream. And that's because in the half hour before natural wake time, there is a dream period. So if you wake yourself just a little bit before normal wake-up time for you, most people will recall a dream. So, the most common cause of excessive sleepiness in the daytime? Not enough sleep. Best way to judge that is whether you sleep longer in the weekends or when you're on holiday. In my case, I sleep 6 hours a night, in bed at midnight, and I wake naturally at 6, and I'm out of bed as soon as the news is finished at 6:05, and I've done that since I was 20. It's just what I do. Now, I was sent away with the Navy a few years ago with enough rank that nobody woke me in the morning. I had somebody who was prepared to come in with a cup of tea. It was quite civilised, really. Apart from the big rubber straps that they had on the bed to keep you in the bunk in a seaway, that looked kind of deviant, really, these leather straps. Anyway, first 4 or 5 days I slept 12-hour nights. Then I settled into a 7¼ hour plus or minus 5 minutes. So my physiologic sleep requirement is 7¼ hours. I've trained myself to manage on 6. It's not enough because I can get a rebound. So that's a good way for you to judge sleep quantity. Now, we do all sorts of things wrong in modern life. I didn't realise, but 1/3 of people in Auckland work some sort of shifts. 1/3. That's an extraordinary number when you think about it. And that's designed to maximise the use of capital, plant. It takes no account of the people who are required to work that time. And shift workers, once you've been a shift worker for about 2 years, your sleep quality never returns to normal. It's always fragmented in some way. Shift workers trying to work between 1 and 3 in the morning make mistakes. It's not normal to have to work between 1 and 3 in the morning. NASA realised this, which is why all of their astronauts and their control room people are required to live in a facility which is painted white with bright light, and irrespective of the clock time, takeoff time is 9 a.m. So even if it's 2 in the morning, clock time, the pilots and the control room team have had their body clock shifted so that they're taking off at their most optimal time, which is 9 a.m, body clock time. Since the Columbia disaster, the engineers checking the seals are also reset, rather than what they did, which was they were checking the seals between 1 and 3 in the morning. They recognised there was some problem. They could not analyse or articulate that problem. The supervisor that they went to for advice could not assess the risk correctly, and as a result, the aircraft was lost. So these are not theoretical things. These are real problems. Now, the current sleep, these classifications here, DIMS is disorders of the initiation or maintenance of sleep. These are the insomnias. All of you have had 2-year-olds. How did you get a 2-year-old to go to bed? Bribery. That works for a while. Punishment. Well, that might seem to work, but they con you, the little beggars. It's routine. So, bedtime, bath time, get into your jammies, sit on the couch for a story, head off to bed. And you'd kiss them on the left side of the forehead, and you'd say the same words. Don't let the big bugs bite. Or whatever. But if you didn't do the same routine, the little beggars wouldn't sleep. And they'd be up repeatedly. We are all Pavlovian dogs. By doing this, we cause the next thing to happen. When that happens, we cause the next thing to happen. It's a positive reinforcement. Which is why it's very important if you wake in the night and you can't get back to sleep, you get out of bed, you sit outside in the living room or the lounge, and then when you're ready to go to bed, you clean your teeth and you go to bed, even if it's 3 in the morning. You do your normal bed-going routine and it will facilitate sleep onset. Lying there in bed thinking, I've got a heavy day tomorrow, you're just not going to get off to sleep. And the more worried you are about the day and the fact that you can't get to sleep, the less likely it is that you'll sleep.
Excuse me. At that time, is it okay to have a drink if it's not coffee or tea?
Yes, it is. But it may make reflux worse, which is one of the things that can disturb night sleep. So you just have to be a little bit careful. But if that's your normal bed-going routine, then that's what you should do. Oftentimes we sleep or we go to bed for too long. It's a cold night. I'm going to go to bed early. Or I've finished my last TV program, I'm going to go to bed early. Going to bed early doesn't help because you're still going to go to bed when your brain says it's sleep time. So what do you do now? You're in bed, but you're not sleepy. And you then think, I'm in bed, I should go to sleep. And again, you're getting into this vicious cycle of insomnia, which you're causing in yourself. You wake in the night, and because you've been in bed and you've slept on and off fitfully, you've had adequate sleep. So instead of being able to get back to sleep in the normal 5 to 10 minutes after a night waking, you'll be awake 30 minutes to an hour. So the key to good insomnia management is what we call good sleep hygiene. Go to bed at the same time every day, have a bed-going routine like a Pavlovian dog, and you constrict the amount of time you're in bed to consolidate sleep. And it means that you might be getting up at 6 in the morning as if you're working still. Bloody hell, I'm retired, you know, I'm allowed to lie in the morning. I hear that a lot, but it's detrimental to sleep. Avoidance of alcohol and caffeine-containing things. Milo doesn't have caffeine, but it has theobromide, which is a caffeine cousin. So the best thing is to have a little bit of water and avoid those sorts of agents. Alcohol will help you get off to sleep quicker, but it fragments sleep later. In my case, 1 glass of wine will convert me from a non-snorer to a snorer. And that's because of its muscle relaxing effect. It's not a toxic effect of alcohol. It's the muscle relaxing effect. And we have a simple snoring scale. Are you a 1-room snorer, 2-room snorer, or a next house snorer? One of my earliest patients came to attention because he was on his 4th partner She was sleeping in the front room, he was in the back room, but it was the neighbour that complained to the Manukau City Noise Control Officer. True story. Racing mind, you just have to clearly separate the day from the night. And in my case, I read a very light, not challenging type of detective novel. And some people have read the same book for 15 years because they never get past the first chapter. The DOEs, the disorders of excessive sleepiness. The most common of these is inadequate sleep. Second most common is snoring and obstructive sleep apnea. Now, snoring is not normal. Snoring means I am obstructing the airway. When you completely block with obstructive apnea, which is like this, that means I'm obstructing the airway and I'm about to die. And it's about 1.5 minutes away. Physiologically, that's very stressful for the brain. Adrenaline and cortisol go up, blood pressure goes up. These are anti-insulin hormones, so blood glucose goes up. So many people with diabetes find high morning blood sugars as a consequence of this. And then because your brain likes you, it wakes you up. And it's unmistakable.
That sounds good. I wake up with
Then you're back to sleep, start to snore, block off again. And that can happen 500 times a night. So that you wake up in the morning and you feel unrefreshed. Go to bed at night, head hits the pillow, and you're out to it. And varying degrees of sleepiness, ranging from people who just aren't firing on all cylinders, right through to my sleepiest patient who I've had to wake 3 times in the course of a consultation. In the 10 years before I saw him, he'd crashed his car 12 times. 8 years before I saw him, he'd killed a pedestrian on a pedestrian crossing, 14-year-old schoolboy. 2 years before I saw him, he'd drifted across the midline on the way to Hamilton and killed an English tourist family in a camper van. His insurance company knew that they shouldn't insure his car, but nobody realised that he had a health issue which was fixed immediately and has never occurred again. So that's obstructive sleep apnea. The other disorders of excessive sleepiness are restless legs, and this is an unpleasant, achy, uncomfortable feeling in the leg which people find very hard to describe. The best description is a crawly ache. It's more common in women than in men. It's more common in pregnant women than non-pregnant, breastfeeding and non-breastfeeding, but it occurs in men as well. Because it occurred in women around with menstruation and pregnancy and breastfeeding, it was thought that it might be to do with iron. And studies showed that, on average, iron levels in people with restless legs were a bit low. And I'm not sure if you've heard about the brain bank in America, where people donate their brains. And all their medical history is attached to the brain. And people who complained of restless legs, when they analysed the brain, found there were 2 parts in the central part of the brain and the putamen where iron stores were low. So when I see somebody with restless leg syndrome, if it's an issue, and quite often it's an intermittent problem that mucks up your sleep for a day or two, isn't a long-term problem, and sometimes it's so bad that people commit suicide. Just drives people spare. My first approach is to do iron levels, and if people are in the lower half of normal, is to replace iron. And then there's a series of medications which can be useful, but it can be a challenging thing to manage. If you're interested in the society, it's called the Restless Leg Society, because we're people of little imagination. It's www.rls.org for those of you who want blue light exposure, but you're best to get that in the morning rather than in the evening. It's different from cramps. Cramps are a metabolic response in skeletal muscle. More common if you've worked hard in the day, because it makes the muscle cells unstable. And the best first treatment for that is to use magnesium or calcium supplements. To do a proper warm-up and warm down in the day when you're doing exercise, and to do some stretches pre-bed. Probably best to do those with your window curtains shut.
What about loss of feeling in the legs?
Loss of feeling in the distant legs, in a glove and stocking distribution, should always be an alarm signal. Now, our nerves live in the spinal cord, and your big toe nerve still has its cell body in the spinal cord. There are nutritional factors which go from the cell body right down the length of the nerve, which may be 1.5 meters long, to the tip of the toe. And if there is a vascular problem or a toxic problem, the nerve is compromised and you get dieback of the tip, what we call glove and stocking distribution. It's just like it can affect the hands or affect the feet. So it's very common in diabetes, and that would be the first set of checks that I would run. It tends not to cause sleep disturbance, but the reheating, tingling paresthesia, that pins and needles as it re-warms, a bit like chilblains, that can disturb sleep. And that can often be due to the fact that you've made the feet warm by getting into bed. And my dear old dad, for example, used to sleep with his feet out of the bed because he had this disorder of night burning feet. And it was very severe, very severe. And we sometimes treat it by sympathectomy, dividing the nerves in the back. But it used to be sufficiently bad that on occasions he would walk around the house, and my mother used to lock up the rifle because it was that bad.
I'm just wondering about some of the things you've talked about so far, sleep apnea, restless legs and bracing mind and those things. How does that fit into the post-polio, with even having had polio and curvature of the spines
Yep.
and chest cavity, all that stuff?
So everything that I've spoken about so far applies to normal people. Now, it's exaggerated in the past polio group if the neck and head muscles were affected because of muscle collapse in the throat, snoring and sleep apnea. There's no increase in insomnia, but if you've got the post-polio syndrome as opposed to the past polio syndrome, you get a lot of self-generated aches and pains, and they can disturb sleep quality. And it causes an EEG picture, a brainwave picture, which we call alpha intrusion, where it's just a measure of the brain waking up for a brief period of time, usually in response to pain.
Excuse me, could you differentiate, please, between post-polio and past polio? I've never heard the wording past polio before.
There are many, many people who've had polio in the past and been left with the physical manifestations of polio, but who don't have post-polio syndrome. Post-polio syndrome, I think you should think of as a pain and disorganisation syndrome with ongoing symptoms. Whereas past polio might just be a flaccid arm with no ill effects other than the loss of the flaccid arm. So I think that's a reasonable definition. Yeah.
Would you think that sleep apnea is one thing that people who've had polio might be susceptible to?
Yes, particularly if truncal and head and neck were affected early. But the other things that can occur, this is a bit more difficult to explain, but many polios will have a big tummy due to abdominal muscle weakness. And when you lie down, that big tummy pushes up against the diaphragm. Now, it's going to be a bit difficult to explain this, but if you've got a rigid pipe, which is the trachea, and you've got a rigid pipe, which are the tubes through the bones of the skull, and they're connected by a floppy pipe, which is the back of the throat, if I stretch those two rigid pipes so that the soft pipe is tight, then it can't collapse. And in physics terms, it functions like a rigid pipe. So air flows through it. If I push up against the bottom of that rigid pipe, which is the tummy against the diaphragm, so I'm taking the stretch off the floppy pipe, it becomes floppy again. And that's what collapses to cause obstructive apnea. So it's not just about being overweight and big-necked, it's also to do with the shape of your face and the length of the chest.
Can I describe it? It actually feels like your throat has collapsed down and you can't breathe. And it does it with me. If I just lay on my back flat, I can't breathe. You have to actually go on the side.
Now there is another problem which is more specific for people who've had polio in the past, particularly if there was diaphragm involvement. And diaphragm involvement could be subtle. You may not have been aware that the diaphragm was affected. But if you found after the polio that you were more breathless doing the same sorts of things that you had pre-polio, then the diaphragm was almost certainly involved. Now the diaphragm is very clever muscle. It's full of slow twitch fibres. They can't work fast, but they're very fatigue resistant, and they'll work forever. If you've lost a third of the innervation of the muscle, so a third of the nerve fibres have gone, the rest of the diaphragm is pretty good at picking up the load, so that you don't notice too much. But when we sleep, particularly when we are in dreaming sleep, you might be fighting off a bikie gang. You can't afford to be acting that out with your bed partner. They will not thank you for it. So when we dream, we are paralysed. And I'm sure those of you who've picked up grandchildren from sleep will, if they're less than 2, when 50% of their sleep time is spent dreaming, you can pick them up and they can be like a rag doll, totally floppy. Hold them up by the leg and they go. Well, that's what you're like for 4 or 5 20-minute periods during your sleep. That affects the skeletal muscle of the throat as well as the skeletal muscles in the leg. So obstructive apneas are always worse during dreaming sleep. Now there's another thing that happens in REM. Our carbon dioxide levels are normally controlled at a very precise level. It is the most tightly controlled bodily function. A 1% rise in CO2 stimulates the brain to breathe bigger or faster. A 1% fall in CO2 will cause us to breathe shallower or slower. Very tightly controlled, except in REM. The chemical sensors don't work during REM, and we're completely reliant on the primitive rat brain part of our brain, which just rhythmically breathes. And that's probably the reason why REM sleep is only limited to 20 minutes, because we can only cope with 20 minutes or so without being able to monitor CO2. So people who've had past polio with diaphragm effects, we can see oxygen levels drop during REM, even in the absence of obstruction. But if there is obstruction as well, then the drop of oxygen is much lower. Now we treat that. Obstructions we treat with a machine which generates a pressure in the airway which simply holds the airway open. It's like a canvas fire hose. Doesn't matter how tangled that is, once it's under pressure, water will flow through it. That's what a c-pap machine is like. But you do have to wear a hose on the nose. Now the extension to that, if your CO2 level goes up because your breathing muscles are not strong enough at night, is to use a machine that senses when you want to take a breath and gives you a bigger breath, and senses when you want to breathe out, and then it drops to a lower pressure, allowing you to breathe out. The only difference between those two machines is about $1,500 to $2,000 of cost. There are some very smart machines which monitor every breath, and when they see the breath getting less and less, they'll give you more breath to 90% of the average of the 10 previous breaths. This is a computer in a small box which is calculating continuously through the night. The only difference with that machine is that that's an extra $2,500. You can do anything for money. There are systems where we can pace the phrenic nerve in the neck, or put a wire around the diaphragm to pace the diaphragm. These are not commonly used in past or post-polio syndromes because you don't have the telephone wires. You've only got muscle. The problem with muscle, as you know, is that muscles become very sensitive if they don't have a nerve supply, which is why those of you who've had limbs will often see fasciculation or flicking under the skin in the area where the muscle was affected, which is a spontaneous discharge of muscle cell. I don't quite know how we got onto that bit, but
At the risk of asking too many questions,
there are no...
when people who've had polio go to a sleep clinic, do you think the technicians understand there might be variations between a regular person, if you like, and a person who's had polio?
Most sleep clinic people would know that. But in fact, we're looking for the same disorders in past polio, post-polio. We'll see more alpha intrusion in post-polio syndrome when we're scoring it. But in terms of how we will manage you, the only thing that we do different is to measure carbon dioxide levels.
The feeling I had when I had a sleep clinic was that when you don't have sleep apnea, so you're all right. And I don't think they explored other possibilities. That's what disturbed me a little bit.
Yep.
They were just looking at sleep apnea only.
Regrettably, sleep services in New Zealand aren't really sleep services. They are OSA services. And in most DHBs, they don't see people with narcolepsy, with ventilatory problems, with restless legs, because the services are swamped with snoring and sleep apnea. Therefore, they have tooled themselves up to just do the high volume, simple stuff quickly.
So that's a disadvantage to us, really.
It is a disadvantage for you, but if you go to the established sleep units, Auckland, Auckland, Wellington, Christchurch are the three that have sleep-trained leaders. Waikato has just, for the last year, had a sleep person. Kat Chang is her name, but she's been on maternity leave for 6 months. So the services have been a little bit fragmented, and as you've already discovered, you own the problem, and you end up educating those that you see. And I'm afraid, I hate to say it, but that's just the reality.
So you should actually say that you've had polio?
Yep.
If you go on sleep apnea?
Yep.
Andrew, if somebody actually has got a respiratory problem and they use the machine at night when they're having difficulty in breathing, and they don't have to use that during the day, does that give the actual diaphragm, I'll say, a rest? Because I know somebody that really does have a breathing problem, and would a PAP machine help them at night and let them have a normal day?
Yes, usually the sequence of progressive respiratory failure is that you're fine 24 hours a day except in REM. Then you start to get involvement of the other stages of sleep, but you're fine absolutely in the daytime. Then you start to have some problems in the daytime as well. And I use the indication for doing something if past polio, post polio are sleepy, then I think they need a sleep study. They may not require ventilation. They may simply require splinting of the upper airway in exactly the same way sleep apnea would require. People who are breathless with features that the heart is struggling to pump blood through the lung, what we call pulmonary hypertension, then we would look and think about getting CO2 levels done through the night. And if CO2 levels go up through the night or are raised in the day, then we would choose a ventilator as an upfront treatment. So there are only 8 of us trained in detail in sleep. There are probably 30 that have had enough training to deal with sleep apnea and restless legs.
And where do they actually go now? You know, is it Littlemore or is it Alderstone? Or
Yes, all DHBs have a sleep service of some sort. Most of them are OSA services. Some are nurse-driven, but with access to a specialist. In Auckland, there are sleep services at Auckland Hospital, which has inpatient facility and can do home studies out of Green Lane, and that deals with all of the North Shore and Auckland. Counties has a sleep service, where I work in my public work, and we deal with about 1,000 a year of people with sleep apnea. And on top of that, we purchase inpatient sleep studies from Auckland, and we purchase inpatient sleep studies from the private sleep lab. So we made an active decision at counties to be largely outpatient based. Now I run the private sleep lab as well, which is a 6-bed facility, the same as Auckland. No, that's at the New Zealand Respiratory and Sleep Institute, which is just on the other side of the Green Lane roundabout. So those of you who are interested, if you want to go there, you're welcome to go after this and have a look at it if you like.
Right, yes, because I do have quite a few polio now that are having a respiratory problem.
Well, the other problem that polio, past polio, post-polio people get is there's a weakness of the cough muscles. And so the normal saliva that you swallow down the wrong way can cause infections, where in a normal person it wouldn't, because you would have coughed it out adequately. I've taken corn kernels out of past polios because they didn't cough properly when they were eating their meat pie. The worst was a sausage, a cross-section of a sausage. And you'd think that that was easy because it was pretty big and completely blocking the windpipe, but it's not very firm, and it was very difficult to get out. And in the end...
One of our patients that was with us, Andrew David Exley, he was a classic example of the respiratory side of what happens, wasn't it?
David was a real gentleman. He was a UN diplomat. He worked in the Middle East and through Europe, remained mobile until his last 5 years or so when he became wheelchair dependent. He was on a ventilator at night for 15 years, and I loved him like a father.
I know you did.
He was a wise gentleman.
Yeah. He was one of our really bad respiratory ones, wasn't he? Yeah.
Well, I've got 5 or 6 people who are on ventilators, and each have their own...
yes, he was. Thank you for that.
back.
About sleep apnea, you talk about inpatient and outpatient services. So you're saying that one is not as effective as the other, or not quite the same standard as the other? What's the difference?
With an inpatient study, we monitor brain waves. So we can see arousals or wakings. On the home study, we're just monitoring breathing, chest movement, tummy movement, oxygen, heart rate. So there are some circumstances which are perfect for a home-based study. Most post-polios, I believe, should be studied overnight in-house because of the possibility of restless legs, the possibility of alpha intrusion disturbing sleep. So just because you're a snorer and you have some obstructions doesn't necessarily mean that's the whole explanation for being sleepy. So my own preference is that I think that that's a referral. You come in at 6 o'clock at night, we watch you overnight, and you go home at 6 or 7 in the morning, and it's sorted in one trip.
I wonder how many have had that.
A few of you have had sleep studies?
Are you able to get a referral from your own GP if
Yes.
you're having problems?
Yep.
Thank you.
So, looking at your little questionnaires that you all filled in, your Epworth sleepiness scale, who scored less than 5? Less than 5. 3, 4, 5. So less than 5 is normal. Who scored over 10? 1, 2, 3, 4, 5. You have some sort of a sleep disorder. More than 10 is abnormal.
Now, if I already have a c-pap machine, but never had a sleep study, I've had a manic hour, just a daytime one.
I did 5, but Joyce,
Well, if you're still sleepy, despite being on c-pap, then it's not adequately doing the job, or you have a second sleep disorder. And that's one of the traps here, that just because people have snoring and sleep apnea.
I reckon, I hadn't done this, but I reckon it'd be over 10.
Okay, there's someone on this side. So this is just a questionnaire that I use to, for people in the waiting, I thought somebody here was sleepy, that I use as a way of taking a sleep history. And it just asks things like, what time do you go to bed, what time do you wake up, how often do you wake in the night. And from this questionnaire, we can start to tease out insomnia, restless legs, narcolepsy, and obstructive sleep apnea. This questionnaire cannot tell us about ventilatory failure, because that needs lung function measurement and CO2 measurement. But those of you who feel that you're sleepy and you want to do something about it, if you fill this questionnaire, take it into your GP, and they will then be able to see and make an initial guess, and then can use that as a basis for referral. There are public services in every DHB. The private service, I think, is unquestionably the best. It's certainly the most heavily in debt, but I have a slight degree of bias, as you might gather.
What about, you sort of catch your breath as if you've forgotten to breathe, and then you take 2 or 3 little breaths.
Yep.
Not all the time, but just now and again.
There are 3 patterns of abnormal breathing that we see. One is obstructive apnea, which is snoring and then often with tummy and chest moving opposite to each other, and then with an opening gasp, that and then a period of rapid breathing. Then we have central apnea, which is a bit like this. As if 4 or 5 breaths have dropped out. And that's a problem with the brain controller of breathing. And then we have Cheyne-Stokes breathing, which is like this. A crescendo, and during that crescendo you're blowing off the CO2 so that the CO2 gets lower, and then the CO2 or the absence of CO2 gets to the control box, and the control box says, shit, no CO2, no need to breathe. And the best way to think about this is like a stuffed thermostat. You've got the thermostat here, you're sitting here, the heat is there. The room gets hotter and hotter and hotter. You start to boil. It finally reaches the thermostat who says, shit, it's hot, and switches the heater off. So the temperature starts to drop there, gets lower and lower and lower and lower. You finally feel that you're getting a bit cold, And then it finally gets to the thermostat and says, shit, it's cold, heat up. Turns the heater on again. And this is the problem, that the sensor is in the rat brain, in the brain stem, and the effector, the heater, is in the chest. And this bit has to talk to this bit, and it does that by the brain knowing that it takes 4.82 seconds for the blood to get from the chest to the sensor. So if the blood takes 8 seconds because your heart's not so good, or if your brain sensor isn't quite as good, then you get this overshoot and undershoot problem. So I'm not sure if that explained your...
No, we're not mentioned it because the doctor said, oh, I think you're just hyperventilating.
Yeah. So you probably overbreathed, CO2 level drops, then there's no need to breathe. So they have a pause. Now I shouldn't say this in the presence of this lovely Labrador, but Labradors are lovely. There is a dog model for obstructive sleep apnea. What do you think it is? Well, it's an English bulldog. So, describe to me an English bulldog. Flat face, fat, big neck, dozy as anything, thick as 2 planks, slobbers all over the place, and it dies young from heart failure. Before it dies, it usually gets diabetes and hypertension. So I'm afraid that's what sleep apnea is.
With the legs that, did you say calcium is good?
For cramps,
Not for the...
not for restless legs. Doesn't usually work for true restless leg syndrome. It can be sometimes out cramps from restless legs.
Yeah, I've had restless legs since my leg's been broken. And that sort of wakes me up.
Right.
Yeah.
True restless legs you can do a test for. And you leave a gun here. You put the patient on a table and you strap their legs still.
Don't race silly behind me, you may do it.
And if they reach for the gun, you know they've got restless legs.
That's lovely. Headlines in the Herald tomorrow.
So classic restless legs people can't often fly, or they don't want to fly because they're confined in the seat. Sometimes they'll even pay for an upgrade just because they have to be able to move their legs. So it's a drive. It's a very unpleasant disorder in its worst form.
So is it movement rather than pain? It's movement. Cramp is pain.
It is a discomfort, and the movement relieves the discomfort. Whereas cramp is pain and sustained stretch is needed to get rid of it. Whereas restless legs, you'll see people just doing this, and it makes the sensation go away. Sorry?
You wouldn't reach for a gun just for that.
Oh, this can be so severe
Severe in pain?
because they're not able, in the pain and the crawly feeling.
Yeah.
It drives people spare. And the movement that they do is to relieve the sensation.
Okay, well I haven't got restless legs.
No, you were describing, I think, cramp.
So can they be irritable to others?
Yes.
Can they be very quick from people around them, or be irritated with people around them?
Oh, bed partners will reach for the gun too. Because often to get off to sleep, they have to ride a bike in bed. You know, there's constant leg movements in order to get off to sleep.
Pins and needles in your feet.
Isn't it strange that if you've got partially paralysed or muscle wastage that you want to be moving them?
Correct. So people who are completely paralysed can still get the sensation of this restless leg, crawling, worm-like. My worst case...
The legs aren't moving.
No.
It goes up here.
It's a brain sensation which is relieved by peripheral limb movement.
Putting the legs up, does that help?
No.
What can you
Putting them over the
do?
bed? No.
What can you do to alleviate it?
For restless legs, it's best treated by boosting iron levels in those that are iron deficient, and sometimes I'll give a trial of iron anyway because it's something simple to do. And then the treatments are dopaminergic agents, which are like Parkinson's treatment. This is not Parkinson's disease, but it responds to the same sort of drug regime. For reasons that I don't know, one drug seems to become tolerant, or the patient becomes tolerant to one drug, and we might have to change to clonazepam or to codeine. And that might work for a month to 6 weeks, and then you have to go back to the first treatment. In its very severe form, it's very difficult to treat, I think.
Is it hereditary?
It runs in families, particularly mother-daughter.
Yeah, my mother had it badly. That's why I just wanted to know.
You're doomed, I'm afraid.
When you say with cramps, calcium, what do? Just get calcium tablets?
Yeah, just get calcium tabs from the supermarket.
Oh, okay. And that helps that?
Yep.
Okay.
There's a magnesium calcium
So
preparation.
you used to give you quinine.
Quinine?
Stage, but they say that doesn't work as well now. Is that right?
Well, quinine does work. There are two reasons why quinine has sort of fallen out of fashion. One is that it doesn't work as well as people thought it did, and that only became apparent when we did placebo-controlled trials. So the person gets a lot of benefit from a pill just because they're taking a pill. So when you do it true placebo control, the difference wasn't all that great. But the real issue is that quinine is extremely toxic to the kidney. So if you think you've got a bit of benefit, but not enough, and you take extra tablets, then you would start to see people with renal failure.
Oh, I see. Because
So-
I've been prescribed for
Yeah.
years and years.
So do you need to have any set strength of calcium or
No, I just take 1 to 2 tablets of the supermarket
calcium?
preparation.
Okay.
Yeah.
And
Yeah.
I'm, I'm very sorry.
Yeah. The other thing you mentioned was about with respiratory, not being able to get rid of sort of like the phlegm.
Yes.
What can they do for that?
If you've got grandchildren, you can, have they got those little trampoline things?
Yeah.
So that works.
What, stand jumping on one of those?
Yep.
Yeah.
Walking works.
Yes.
Because it makes you take bigger breaths,
Yes.
and huffing as opposed to coughing. But we've got two experts here.
What do you mean by huffing?
Huffing is a,
Yeah.
and that shifts secretions from smaller airways to the bigger airways,
Yes.
and then you can cough.
Oh, okay.
We've got some patients where we humidify the air so that they wear nasal prongs connected to a thing that looks a bit like a c-pap machine,
Yeah.
which just moistens the air to make the secretions thinner.
That's all right.
There's an agent called mannitol, which is a sugar, which you can take by an inhaler, and that attracts water into the mucus and makes it easier to cough. And then the ultimate machine is something like a jacket that you wear that vibrates you, which
To
is
make it really
which is called the cough assist machine.
Yes. Oh, okay.
And there are little equivalents, because we're very cheap and smart, where you blow into a device which has a ball or a flutter valve which vibrates the air column,
Yes.
which helps to shake the mucus, which changes its rheology, its stickiness.
Yes.
Just like sand on a beach. If you wiggle the sand, it becomes liquid. If you wiggle the mucus by these flutter valves and PEP valves and the things that you guys know about, you've probably got some in the boot of your car, have you?
So you only do the huffing when it's a problem.
Yes. Yeah.
You don't do it regularly.
So some people do it regularly if they have bronchiectasis or cystic fibrosis.
What about simple plastic devices for snoring? Something that goes in the mouth or the nose, something like that?
Yep. There are 527 devices that have been invented for the management of snoring. And that probably tells you something.
There's a lot of rumours.
People are desperate for a cheap, easy fix.
Tells you three things. This is an extremely common problem. Secondly, people are desperate and are prepared to pay money. Thirdly, nothing works for everybody.
Do they work for somebody?
But they do work for some. So my standard approach to snoring and sleep apnea is to do the simple things that I tell everybody and everybody ignores. Lose weight, avoid alcohol, sleep regularly, get a good bed going routine, be a good person. You know, the TUI ad comes to mind frequently in my clinics. Then for severe sleep apnea, c-pap, which works for snoring. It's a very intrusive treatment for simple snoring. But when you're on it, you will not snore. And that's simply acting as an internal splint to hold the airway open. Dental devices work, and there are two. There are mandibular advancement splints, which bring the lower jaw forward so that you sleep like this at night. And what that's doing is pulling the tongue forward, because the tongue's attached here. It takes a week to 2 weeks to get used to it. You slobber all over the pillow for the first week or two, but the mouth does get used to it. The best of them, total price, if you add all of the things together, because it's made for you. So you take impressions of the teeth, you make a mould against those impressions, then you fit it to you, and you may have to do some adjustments. So it's 4 or 5 visits to a dentist, $2,500 to $3,500. Now there are some that you can buy over the internet, and the one that's advertised at the currently is called the Z Quiet, or except it's Z Quiet on, I think it's Quiet. And that's a boil in the bag type device that you just bite into, and it's just preset at 1 degree of advancement. The $1,000, $2,000 to $3,000 one that I was describing is adjustable. So you can bring it forward slowly over time to allow your jaw joint to adjust. And then there's a cheap device called the tongue stabilizing device, or the TSD, made by Avio, which is a dentist in Dunedin. Very clever idea, and it's like a champagne cork. You poke your tongue into it, and it's held in by vacuum. And providing you don't bite your tongue, it's been shown in trials to be very good. The third type of treatments are the head positioning treatments, like a physiotherapist's soft collar, which bring the neck forward and tilt the head back. So neck forward, head tilted back. And that works for a percentage of people. There are pillows that are shaped in a certain way which tilt the head. There are sprays which are used, which are soaps. They're surfactants. And what they do is to reduce the stickiness at the back of the throat. It doesn't change the vibration frequency, it reduces the noise of unsticking the surface tension. And these are things called silence, snore no more, and there's a third one whose name I can't remember. There's a trial that's been done using a green banana. A green banana smoothie taken before bedtime might allow your wife time to get to sleep before you start to snore. There's a trial been done with a didgeridoo. If you play a didgeridoo for a half an hour 3 times a week, you will not snore. You may still not be popular, but because of these ideas, the voice therapists are now learnt the didgeridoo. And his flatmates commented, "God, your snoring's gone." So an Australian sleep doctor who was staying in the flat on the way to the UK thought, this is a great idea. I wonder if it's the truth. So trained 5 others, published a paper, and it's all on. So science is a very serendipitous sort of activity.
At the end of all this, you're still going to tell us that there's not one treatment for it?
Correct. I'm afraid not. There is only one thing guaranteed to work 100% of the time. And it does work. And until 1980, it's the only treatment we had. It's not a popular treatment because it involves a tracheostomy. Guaranteed though, 100%. So being propped up helps because your tummy falls away. It pulls on the bottom end of that Starling resistor that I was telling you about. Definitely helps. And there are some surgeries. Sorry, I meant to go on to the surgeries then.
I was going to ask for surgery.
Then there are 4 sorts of surgeries. There are surgeries designed to facilitate the use of other things. And that's mainly to improve the nose. Straighten the nose, trim the turbinates, remove the tonsils. And since the fashion to remove tonsils has reduced, we're seeing much more sleep apnea in kids because they're being left with big tonsils. And then there is surgery to the soft tissues. This is the soft palate. If we shorten, stiffen or trim it, you can't snore and you'll be cured. Problem is, quite a bit of the noise and the obstructions come from the base of the tongue or immediately above the voice box. This is a multi-level problem, which is why if you have a uvulopalatopharyngoplasty, a trimming operation, about 2/3 derive benefit, but within 2 years, a half of those have got it back again. So it's a sustained, successful treatment in 1/3. Another form of surgery that is useful is bariatric surgery, because this does relate to weight. And if you lose weight, sleep apnea will improve. And in fact, 2/3 of people who've had bariatric surgery weight loss lose their sleep apnea completely. And then the last type of surgery, which unfortunately you're just a tad old for, is to take your face off. It's only attached by 3 places on either side. We can pull the face forward by up to 1 centimetre, split the lower jaw to meet the upper jaw, we wouldn't change your appearance at all. All we would be doing is rotating the face forward. Now, the best time to do that is when people are in their 20s, when we know we don't snore. And if somebody proves that we snore, who the hell cares? And talking to them about what's going to happen when they're 50 doesn't matter, because nobody's going to reach 50. God, that's old. So there's a disconnect between the optimal time to do the surgery and the realisation that surgery would be useful. So Barry, sorry to use you as an example, but come forward. So if you look at Barry in profile, so people on this side will see that his mid-face is set back a little bit, which gives him a strong chin and a strong forehead. So you might think that his chin's abnormal and he's bloody intelligent.
But the face is like that, basically.
Whereas I would look at this and say, I could cure your sleep apnea by just taking your face off, bringing it forward 1 centimetre, and you'd be cured.
So one last question, the next step, what about pharmaceuticals or pseudo-pharmaceuticals?
It's being worked on. There was a treatment that was thought to be successful, but in volunteer rats caused liver cancers. Not quite ready for prime time yet.
What about common old sleeping pills or pseudo-sleeping pills?
Well, sleeping pills make sleep apnea worse. The reason that it makes sleep apnea worse is that it's a relaxant. If you relax the upper airway, which you're relying on to be open, it's just like alcohol. Makes
So will it work on DIMS?
Sorry?
Will it work on DIMS?
Yes. Yep. So sleeping tablets have a very good use. There are 2 or 3 families of treatments, really. There are the Z drugs, zopiclone, imivane, that family of drugs, which have the least impact on brainwave architecture. And they're probably pretty safe. They're best used for short-term insomnia. The sort of insomnia that you get when you've shifted to a new flat or you're in a new job and things are a bit stressful, you can't switch your mind off, but it's a temporary problem. Then there is circadian or melatonin, which replaces your natural melatonin. And as you get older, your melatonin levels drop. So there are melatonin replacements available. They do 2 things. They increase sleep propensity, but if you take them at the wrong time, they will also reposition your sleep. So melatonin should be taken in low dose about an hour to an hour and a half before natural bedtime, as part of your Pavlovian going to bed response. And then the other group of drugs are the antidepressant family of drugs, which work for people who have DIMS, insomnia, as part of a depression or an anxiety state. Now, there are some other agents that you can get over the counter. Most of those are sedating antihistamines, because histamine receptors in the brain can contribute to drowsiness. And many of you would have seen that when you had bad hay fever and you took something like, I've just forgotten the name of it, Sudafed, that it would make you drowsy for a bit. And that's one of the reasons that it's used as an anti-seasickness medicine too. It's just sedating the brain. The other strategy, of course, is to take waking up drugs in the daytime. In other words, not worrying about what's happening at night, trying to treat the daytime symptom. And of course we all do that, and caffeine is the most common, but methylphenidate or Ritalin, dexamphetamine and modafinil are all agents that can do that. Their only problem is that they're only subsidised if you've got diagnosed narcolepsy. So most people would have to buy it, and they're $3 a tablet.
And Polios don't like taking drugs.
No, but that's not always a rational response. You know, if you nod off 15 times on the way to Taupo when you're driving on the same road that I'll be driving in 10 days' time, please take the drugs.
Dr. Veale, just looking at the way everyone is responding to your information here and seeing our two physiotherapy friends writing as many notes as they possibly can, I'm quite certain that everyone here has learned as much as I have. I always knew that I didn't want to be a shift worker, and now I know why. So thank you very much indeed for the information you have given us. It is well received, and we will carry it with us for a long time.
My pleasure.
Thank you very much.